here with Monty Pal. We're at Uromigos Live 2023. Monty, we want to talk a little bit about the IO-refractory space. As you're well versed, IO doublet standard of care. Most patients, certainly in the US, are getting immune therapy up front, if not in the adjuvant setting now. And now we've created this IO-refractory space. So talk to us maybe just general terms about how you approach that patient, sort of both second, third line.
Yeah, sure. Well, I mean, if I had to sort of look at my current practice patterns, as you might know, I tend to start patients on Cabo-Nivo up front. Yeah, we may have discussed that before. So it really actually leaves a huge void in the second and third line setting, right? Because we don't really have a ton of prospective randomized data till recently to really sort of suffice that space. So I would say that in the second line, I tend to put the more robust patient on Len-Ev.
Okay.
I tend to actually put the more perhaps infirm patient, the one who's really challenged by toxicities, that's a lot of patients for me after Cabo-Nivo, on tivozanib. So I'll tend to use that as actually sort of my second line agent.
So talk about NCCN guidelines in this space. I think it's kind of a list of drugs, and it's kind of almost everything, right, in this space of refractory?
Right, no, that's true. And the new NCCN guidelines have this division between the IO naive and the IO pretreated population. And in the IO pretreated population, there's a lot of latitude. And I really think that's where clinical judgment comes in, right? And that's where, you know, you really need to look at that patient and see what you think they can physically tolerate. Lenvatinib and everolimus, you know, we've done some dose finding studies with it. It's a challenging regimen. Even if you tinker with the dose a little bit, I find that most patients really suffer a lot from colitis. With tivozanib, a lot less in the way of hand-foot syndrome, a lot less in the way of fatigue. I just think it's a regimen that folks can tolerate a bit better in that salvage space.
Agreed. I mean, for me, when I'm moving away from curative regimens, i.e. moving away from IO, then it's really all about disease control and tolerability. And as you say, for a more indolent patient, the tolerability is probably more important. A more symptomatic patient, you might use a more aggressive regimen. And as you say, there's relatively limited data. So I think the two drugs with the most data in the setting are tivozanib. I'm going to ask you to comment on TiVo-3, and then also some recent data on belzutifan. I think they're going to be the two drugs that occupy this, let's call it third, fourth line space. So let's start with TiVo-3, presented and published, I don't know, a couple years ago now, predominantly third and fourth line, Tivo versus sorafenib. So tell us sort of briefly about the high-level results.
Yeah, absolutely. And this obviously is a study you led. It's interesting presenting these results to you. But, you know, having said that, was a trial that compared those two agents, tivozanib and sorafenib, in patients with 2 to 3 prior lines of therapy. You know, there had been one trial prior to this that really replicated the design looking at davitinib. It was flat negative. I think that a lot of people were skeptical, actually, about what this result was going to look like. But there was a PFS advantage, a response rate advantage. And I actually had a handful of patients on the study that had quite durable responses with tivozanib. And I think the data really points to particularly the post-IO patients, which was about 25% of the study population, really having some nice durable responses.
Yeah, I think that was, when I first saw these curves, that was maybe the most pleasantly surprising thing is that you do almost see an IO-like tail of the curve. You know, again, it's still TKI, and is that from prior IO lingering? Is it just that it's so well tolerated people can stay on it? But I was sort of struck by that as well, and I think the updates in the long-term data has borne that out. And I agree, I tend to use it in a third-line setting. So if I'm using IO-TKI, Len-Pembro, or Ipi-Nivo, I tend to give Cabo second, and it's pretty much, at present, my go-to third-line drug. We had some recent data at ESMO, LIGHTSPARK-005, that looked at HIF inhibitor belzutifan, currently approved in VHL syndrome, inherited clear cell RCC. This was in sporadic RCC versus everolimus, in also a predominantly but not exclusively third and fourth line setting. I think 90% were third or fourth line. So just give us those high-level results, and then where, assuming approval, where are you going to use that drug?
Yeah, so, you know, really interesting data. There was a progression-free survival advantage with belzutifan over everolimus. I don't think that was much of a shocker. The PFS median estimates were actually spot on with each other, around 5.5 months. And that actually sort of mirrors what we saw with tivozanib, quite ironically. Response rates in the 20% ballpark with it. There certainly were some durable responses, a real tail on the curve. You know, I have no doubt that it's probably going to get FDA approval relatively soon. In terms of where I'll sequence it, you know, I did with belzutifan data what I do for other trials. I looked to somebody smarter for reassurance. And I was actually sitting in the ESMO hall next to Bernard Escudier. So
pretty smart.
Doesn't get better than that. So, you know, I looked over and I said, I'm not blown away by this. What do you think? And he kind of nodded his head in agreement. Because, you know, to be honest with you, we saw from the phase 1 data set, right, PFS that was nearly 12 months, right? We had a lot of high expectations for belzutifan in this setting. And in a real world setting, which, I think that this phase 3 trial perhaps replicates better as opposed to a phase 1, it just didn't quite meet that mark. The big challenge for me with belzutifan is that although it's very well tolerated, you're waiting a long time for those responses. And even though we are in sort of palliative mode with patients, by the time we get to second and third line, you still do need to control disease too, and you do need to control disease quickly, right? That's really what the palliation is for. So I think I'm probably going to stick with my current regimen and put TiVo first and belzutifan later.
Okay. Yeah, I think we have a lot to learn. Obviously, we've just seen the high-level data, subsets and all those sort of analyses pending. I think we all agree it's the prime drug for a biomarker.
Yeah.
Right? I mean, it's a tumor-targeted, transcription factor-targeted. We don't yet have data on that, but obviously we'd love that, as with any drug. And what I've heard is clinically, just what you said is, that bulkier, a little more symptomatic, I need an earlier response, I'll probably give them TiVo or similar TKI. But if you have time to wait, it's certainly a better tolerated drug than TKIs in general, right? Yeah. Even than TiVo, which is a pretty darn well tolerated drug. And I think that's TiVo's calling card, and it's especially belzutifan's calling card. So I think a lot to learn, in terms of how to use these drugs in sequence, one after the other after one. So there'll be a lot of data that comes out. Let's just end with this. What else is exciting in the refractory space? Like, where do you think the next real advance is going to be? Is it belzu combos? Is it some novel mechanism? Where should we be headed?
I think that a lot of us in the field are pretty unified in stating that belzutifan does seem to be a well combinable drug. And this was really shocking to me because, we'd experimented with this in yesteryear with vertical blockade, right? We tried, sunitinib and bevacizumab, which was a disaster, right?
Yes.
But, with that in mind, belzutifan and cabo, belzutifan and len, these seem to pair really well with perhaps additive responses, in my opinion. But nonetheless, I think that those additive responses are going to yield positive phase 3 studies in earlier settings. So I think we'll see it in combo.
Yeah, awesome. Great. Thanks for the discussion. Appreciate it.
You got it.